A lot of my patients are fascinated with biohacking, longevity, and looking for ways to optimize their health. They correctly perceive that modern medicine is really only good at detecting and treating severe disease, but not as much emphasis is put on prevention. Even cancer screenings, as I've argued elsewhere, don't really reduce mortality, so other than vaccines, modern medicine seems to have very little to offer for those who want to maximize their longevity and optimize their health span. But what if we could predict who was at risk of getting heart disease? What if there were a molecule that we could measure that was a confirmed risk factor for developing heart disease, dementia, or even fractures in old age? What if lowering that molecule was as simple as taking the right amounts of B vitamins, B12, B6, and folate? We're going to talk today about that molecule, homocysteine. What it is, how it's made, how your body metabolizes it, what things can cause it to go up, and how to lower it. I think that understanding homocysteine is the critical key to understanding any other cutting-edge biohacking technology, including the new genetic and epigenetic tests that will be coming out in waves in the coming years. So bear with me through this deep dive. It's really important that you listen all the way to the end, because if you understand what I'm saying here about homocysteine, you can apply it to all future attempts at health optimization, testing, and longevity. What is homocysteine? How is it made? Okay, so we're going to get into the weeds a little bit here. I know I said to listen to the end, but feel free to skip to the next section if you don't care about biochemistry. If you want a deeper understanding, here's the biochemistry and metabolism of homocysteine. Homocysteine is an amino acid. Those are the building blocks of proteins, and homocysteine is an intermediate step in the biochemical pathway that your body uses to convert the amino acid methionine into the amino acid cysteine. As you can see in this diagram, homocysteine is created from methionine by removing a so-called methyl group, which is a bond to a carbon atom, and that carbon atom has 3 attached hydrogens. Homocysteine can then be metabolized by one of 2 divergent pathways. The pathway to make cysteine is called transsulfuration and is catalyzed by an enzyme called cystathione beta synthase. We're going to call that CBS here for short. And that enzyme requires vitamin B6 as a cofactor in order to work. The other pathway is called remethylation, which is basically just the process of going in reverse to change homocysteine back into methionine. This reaction can be catalyzed by betaine homocysteine methyltransferase. That's a mouthful, but it's also catalyzed by an enzyme called methionine synthase. Just like the CBS enzyme requires B6 as a cofactor, methionine synthase requires methylcobalamin, which is derived from cobalamin, and cobalamin is another name for B12. It's also important to notice here that methionine synthase requires the conversion of the active form of folate, that's 5-methyl tetrahydrofolate, into tetrahydrofolate. And that's where the methyl group comes from. It's from the methyl tetrahydrofolate going back to tetrahydrofolate. In order for your body to make that active form, the so-called 5-methyl tetrahydrofolate, from folic acid, it requires an enzyme called methylene tetrahydrofolate reductase. It's also called MTHFR. You may have heard of that. And it uses vitamin B2 as a cofactor. That'll become important later on. The important thing to take away from all of this is that homocysteine is metabolized by biochemical pathways that require B6, B12, and folic acid systems to be working correctly. What we'll see is that deficiencies of these B vitamins will cause elevated levels of homocysteine, but so can genetic disorders that cause deficiencies of enzymes like CBS. Now, how were the dangers of elevated homocysteine discovered? In 1969, Dr. K.S. McCulley in the American Journal of Pathology reported the autopsy findings of a 7-week-old infant who died as a result of very high plasma levels of homocysteine due to a rare defect in a gene in the vitamin B12 metabolic pathway. At autopsy, the infant's arteries showed very severe stiffening from plaque buildup, like those of an 80-year-old, with certain features that reminded Dr. McCulley of similar findings he had seen in other children who had a disease called homocysteinuria, which was caused by genetic CBS enzyme deficiency. Although homocystinuria is a rare autosomal recessive disorder, it is characterized by several abnormalities in body shape and function, but also characterized by excessive blood clotting, called thromboembolic disease, as well as being characterized by severe premature coronary artery disease, even in infancy, with stiffening and plaque buildup in the arteries called atherosclerosis. Since these two different genetic diseases both had in common major elevations in homocysteine levels, McCulley hypothesized that the arterial damage found in association with both diseases was caused by homocysteine, or by some derivative of homocysteine. This hypothesis was largely ignored for almost 20 years, but then in the 1990s, a surge of interest generated many epidemiologic studies which showed that even moderate elevations in plasma homocysteine levels in the range of 15 to 20 micromoles per liter are a common risk factor for vascular disease. There is a ton of evidence from prospective cohort, cross-sectional, and case control studies with more than 100 studies, over 12,000 patients in total, confirming the association between elevated homocysteine levels and vascular disease. There are several possible biochemical pathways that could explain this. First, elevated homocysteine has been shown to induce mRNA expression of inflammatory cell signaling molecules that are called cytokines, including monocyte chemoattractant protein 1, MCP1, as well as interleukin 8, that's IL-8, in human aortic cells that have been cultured in a lab. MCP1 in particular increased within 1 hour of exposure to homocysteine, reaching a maximum after 2 to 4 hours, and took almost 24 hours to return back to normal levels after exposure to homocysteine. This mRNA induction was seen with levels of homocysteine as little as 10 micromoles per liter. Exposure to other molecules like L-cysteine or L-methionine had no effect on MCP1 levels or mRNA expression. Only homocysteine had this inflammatory chemical effect. These signaling molecules, these cytokines, are also seen in inflammatory conditions like sepsis. Furthermore, in another experiment, elevated levels of homocysteine caused vascular tissue to increase in thickness, with increased collagen production and cell density. Collagen is the major connective protein of the body and is a major component of scar tissue. In this experiment, collagen production shot up by more than 200% after exposure to elevated levels of homocysteine. Interestingly, adding a form of B12 called aquacobalamin to the homocysteine mixture controlled the collagen production and cell proliferation. But even aside from the biochemistry, in the real world we do see a significant association between elevated homocysteine levels and vascular disease, including everything from venous thrombosis, which we'll talk about next, to lower extremity arterial disease, to coronary artery disease. Meta-analyses of epidemiological data have suggested that for every 5 micromole per liter increase in homocysteine, there was a 20% increase in the risk of coronary artery disease. Some authors estimated that almost 10% of the population's risk was attributable to homocysteine. Another meta-analysis by Eichelboom confirmed these findings, concluding that, quote, there is a strong dose-dependent positive correlation between plasma homocysteine levels and risk for cardiovascular disease that is independent of other known risk factors, end quote. Yet another meta-analysis in 2002 drew data from 12 prospective studies involving 1,855 coronary heart disease events and 463 stroke events. Even after discounting the effects of other known cardiovascular risk factors like smoking, a 25% lower homocysteine level, about 3 points, was associated with a 10% lower risk of ischemic heart disease and stroke. An analysis done for the United States Preventative Services Task Force, that's USPSTF, found that the risks of elevated homocysteine levels were independent of the standard Framingham risk factors, that's high blood pressure, diabetes, and cholesterol. In addition, some genetic studies have also shown increased risks. For example, one meta-analysis of 40 different observational studies involving 11,162 patients who were homozygous for the so-called thermolabile TT variant of the MTHFR gene, which produces higher homocysteine levels, and 12,758 matched controls, the MTHFR TT genotype was associated with a higher risk for coronary heart disease. Now let's move on to venous thromboembolism. That's another area of risk, also called VTE. It's a combination term for blood clots that are formed in the veins instead of the arteries. This includes mostly the so-called deep veins in the legs, and the possibility of those clots breaking free of the legs and shooting up to the blood vessels of the lungs, causing a pulmonary embolus, which can be deadly. Meta-analysis of case control studies have shown that elevated homocysteine levels above twice normal are associated with a 2.5 to 3 times risk of venous thromboembolism, or VTE. More moderate elevations may be associated with a risk of repeated VTE after a first episode. However, some other studies have concluded that these associations were due to confounding factors. A large case control study of over 3,000 individuals showed that mild elevation in homocysteine levels was no longer associated with VTE risk if statistical controls were placed for BMI and smoking status. So it's a bit less clear than the association with coronary artery disease. Dementia is another area of concern, specifically in regards to neurotoxicity and the development of Alzheimer's disease. Biochemically, we know that homocysteine is rapidly oxidized in plasma, producing reactive oxygen species. Some of these toxic products are also believed to play a role in the genesis of neurodegenerative diseases. In particular, homocysteine and its metabolite, homocystic acid, are very potent stimulators of the N-methyl D-aspartate, that's NMDA, receptors, and are neurotoxic to neurons that have been cultured in a petri dish. We also do see a corresponding association between higher levels of homocysteine and higher rates of dementia, although the evidence is not as strong as for heart disease. Case control studies have reported a correlation between Alzheimer's disease and high homocysteine levels. The most rigorous of these studies was done by Clark et al., who evaluated 164 Alzheimer's disease patients. 76 of them had pathologic confirmation of the diagnosis of Alzheimer's disease. They found a significant difference in the distribution of total homocysteine levels between the patients that had Alzheimer's and other age-matched controlled patients. They found that having a homocysteine concentration in the upper third percentile was associated with a 200 to 450% increase in the risk of having Alzheimer's disease. Now, a couple of notes on blood collection methods. I want to take a moment to discuss a couple of technical issues that are important for accuracy if you decide to get your homocysteine levels checked. First, the blood must be refrigerated immediately after collection, since levels will rise if the blood is kept at room temperature. It's about a 10% rise per hour. Thus, immediately after drawing the blood sample in an anti-clotting tube, an EDTA or heparin tube, it must be processed by centrifuging and separating the plasma from the red blood cells. This cannot be done in a standard SST or so-called tiger top tube because of the long clotting time that is required for that tube. After removal of the red blood cells, the sample is much more stable and can last for up to 4 days even at room temperature. Secondly, the timing of the collection is important. Usually we check fasting homocysteine levels, but there is some evidence that almost twice as many people would test as high if the blood were drawn after a methionine dose. Up to 40% of people only show elevated levels if the blood is taken after a methionine challenge. Both fasting and post-methionine levels are independently associated with increased risk of vascular disease in case control studies. Furthermore, there is no consensus about the definition of the normal range. The upper level is commonly cited as 15 micromoles per liter, but studies on targeted segments of the population have shown that that is far too high in well-nourished populations without obvious vitamin deficiency. Some report that anything above 6.3 micromoles per liter represents an increased risk. Now, you might be asking, what things can cause elevated homocysteine levels? Number one is genetics. As mentioned at the very beginning, severe elevations in homocysteine were first noted to be important in genetic diseases affecting related enzymes. Homocystinuria is most commonly caused by homozygous deficiency of the CBS enzyme due to a genetic abnormality present in both pairs of chromosomes. In this condition, homocysteine levels can reach up to 200 micromoles per liter. Heterozygous deficiency of the enzyme, where only one of the chromosomes is affected, occurs in about 1 to 2% of the population and is associated with elevated levels of homocysteine up to 20 to 30 micromoles per liter, and recent epidemiologic studies suggest that heterozygotes are at increased risk for premature atherosclerosis. Homozygous complete deficiency of the MTHFR gene is rare, but it does result in severe hyperhomocysteinemia, that's elevated levels of homocysteine, and early death. A much more common mutation in the MTHFR gene is a C to T transition at codon 677. That's called the 677C-T transition. The heterozygous polymorphism is common, including almost 5 to 10% of Caucasian populations. People who are homozygous for this C677T MTHFR mutation, that's a mouthful, but people who are homozygous for that mutation have slight elevations in homocysteine levels and are at increased risk for premature vascular disease. Other things that increase homocysteine levels include chronic medical disorders and conditions like diabetes, rheumatoid arthritis, lupus, renal failure, malignant neoplasms and leukemia. Severe psoriasis can do it, hypothyroidism, inflammatory response to illnesses, cardiac and renal transplantation. Drugs can also increase homocysteine levels, including sex hormones, some anticonvulsant medications like phenytoin or carbamazepine, cholestyramine, cholestipol, and nicotinic acid. Metformin, which also impairs B12 absorption, can increase homocysteine levels as well as thiazide diuretics, cyclosporine, methotrexate, and nitrous oxide. Lifestyle factors can also raise homocysteine levels, including tobacco use, physical inactivity, obesity, and stress. Dietary factors like high alcohol intake, high coffee intake above 4 cups per day can also increase homocysteine levels, as well as anything that increases the total amount of methionine that you're consuming, because methionine is the source of homocysteine. So Brazil nuts have very high levels, as well as lean beef, Canadian bacon, chicken breast has 490 units of methionine. Fish like salmon, lobster tail, eggs, crab, canned tuna, pork chops have almost 1,500 units of methionine. Roasted turkey and cured ham, one slice of which has nearly 2,000 units. Demographic characteristics like increasing age, male gender, and postmenopausal status are also associated with elevated levels of homocysteine. Number 3 is vitamin deficiencies. As I noted earlier, we know that deficiencies of B vitamins can cause elevations in homocysteine levels. This has been shown in multiple studies. Almost 66% of all patients with elevated levels of homocysteine are due to relative deficiencies of folate, B6, and/or B12. We also have evidence that after the FDA required grain products to be enriched with folate, which was done to reduce neural tube defects, we have also seen a reduction in homocysteine levels by about 7%, and the number of patients with significant elevations, greater than 13, was cut nearly in half by that requirement. These observations have prompted the use of vitamin therapy for prevention of cerebrovascular disease in randomized trials. The VISP trial, Vitamin Intervention for Stroke Prevention, the NORVIT trial, the Norwegian Vitamin Trial, and HOPE-2, that's Heart Outcomes Prevention Evaluation, all used B vitamin supplementation to reduce homocysteine levels. For venous thromboembolic disease, there has also been a double-blind, placebo-controlled trial entitled Homocysteine Lowering by B Vitamins and the Secondary Prevention of Deep Vein Thrombosis and Pulmonary Embolism. And as for Alzheimer's disease, there was a controlled trial of homocysteine lowering and cognitive performance, also a double-blind placebo-controlled trial. Each of those trials successfully demonstrated that supplementation with B vitamins could reduce homocysteine levels by 18 to 27%. The studies provided doses from 400 to 1,000 micrograms of B12, 25 to 50 milligrams of B6, and 0.8 to 2.5 milligrams of folic acid. If you want to take steps to reduce your homocysteine levels, you could consider avoiding high methionine foods like pork and crab, as well as supplementing B vitamins, avoiding excessive coffee, and smoking. So, let's reflect. Let's consider where we're at. Elevated homocysteine levels are noted in several genetic conditions that cause premature atherosclerosis and heart disease in infants and children, as well as in the rare case of homozygous MTHFR, that's TT, genetic abnormalities. In population studies, including epidemiological studies as well as case control and cohort studies, we see significant associations with vascular disease, especially heart disease and dementia. Homocysteine levels and MTHFR status are excellent predictors of all-cause mortality, with a 33.6% increase in risk of death for every 5 micromole per liter rise in homocysteine levels, as well as cardiac event risk. We know that homocysteine levels also naturally rise with age, are higher in males and higher in postmenopausal women. We also know that things like alcohol, smoking, and obesity are also associated with higher levels of homocysteine, along with inflammatory conditions like rheumatoid arthritis, severe psoriasis, and severe infections, as well as some cancers. We know that in the lab, blood vessel cells create excessive tissue thickening with collagen, just as we would see in wound healing, and scar tissue formation by more than 200%, and increased secretion of inflammatory cytokines like MCP1 and IL-8 in response to homocysteine. Furthermore, in response to homocysteine exposure. Furthermore, we know that deficiencies in B vitamins can cause elevated levels, and in patients who have elevated homocysteine levels for any reason, including genetic causes like MTHFR 667C to T, B vitamin supplementation can reduce homocysteine levels effectively by about 18 to 27%. If you want to get your homocysteine levels checked, you can ask your doctor, although bear in mind that insurance companies generally do not cover the cost of the test. Dana White has been working with Gary Brecka, who has, quote, a clinically photographic memory and an undergraduate degree in biology and worked in life insurance. Gary recommends that Dana should take B vitamins to reduce his homocysteine levels and claims that Dana will live 3 times longer than he would have if his homocysteine levels were higher. He is, if you'll pardon the pun, dead wrong. Now, let's go through some actual studies. In my previous video, I tried to distinguish between evidence and storytelling. In this video, I hope I've given you a taste of what storytelling looks and feels like. I hope I was able to convince you of the importance of homocysteine levels and get you talking and get you excited about maybe taking B vitamins if your levels were elevated. I've used storytelling in a way that I hope is convincing, because it turns out if you're getting excited about getting your homocysteine levels checked, or getting a genetic test for MTHFR gene abnormalities, or taking B vitamins to lower your homocysteine levels, then my storytelling has completely misled you. Let's go back to those double-blind studies. Each of the double-blind studies I mentioned earlier, VISP, NORVIT, and HOPE-2, showed no benefit in reducing cardiac events or mortality by supplementing B vitamins. The study on Alzheimer's similarly showed no benefit, nor did the study on VTE. In fact, each of the studies I mentioned had something in common. The elevated homocysteine levels that were checked at the beginning of the trial did relate to an increased risk, but when the B vitamins successfully lowered the homocysteine levels, the risk of the disease did not change. And actually, in several of the trials, there was a trend towards harm. This is exactly how online longevity gurus like David Sinclair, Andrew Huberman, Peter Attia, and so forth lead you astray, with beautifully told stories, excessive detail about irrelevant biochemistry, and practical tips on changes you could make. Of course, they don't mention that we've studied heterozygous MTHFR 677C to T variant patients, and they have no increased risk. Only homozygous patients have increased risk. They certainly won't mention the double-blind studies I listed before that showed definitively that there is no benefit to reducing homocysteine levels using B vitamin supplements. And they won't clarify that all they're doing is baffling you with bullshit, giving you the old razzle-dazzle, leading you on with promises of eternal life and the fountain of youth. Brian Fuckface Armstrong won't mention that the biological age markers he's using don't correlate to anything in the real world, and he could have saved himself millions of dollars by just using Photoshop to print a chart that looks like this to make himself feel good. In fact, he can borrow mine. It's free, and it's just as useful as his biological age tests. According to the same tests, this guy reduced his biological age from 67 to 47, and I don't know about you, but I'm not placing bets on him living 20 years longer than average. So what did the studies actually show? I alluded to this earlier, but let's quickly go through the studies for completeness. The VISP, Vitamin Intervention for Stroke Prevention, included 3,680 stroke patients, followed them for 2 years, comparing high-dose multivitamin therapy with placebo to try to reduce the risk of future strokes, heart disease, or death. The homocysteine levels were reduced by about 18%, but there was no effect on the outcomes. The baseline homocysteine level, before reduction, was an independent predictor of the outcomes. The Norwegian vitamin trial, Norvit. This trial included 3,749 patients with a heart attack within 7 days of starting treatment. The treatment was B vitamin supplementation with various combinations of folic acid, B6, and B12 compared to placebo, and the patients were followed for 5 years to see if they had another heart attack, stroke, or sudden death. Once again, there was no difference from placebo, despite a notable reduction in homocysteine levels by 27%. In fact, in the group that received all 3 B vitamins, there was a trend toward increased risk of vascular events. Just like in VISP, the baseline homocysteine level before reduction was an independent predictor of vascular events. And then there's HOPE 2. Studying 5,522 Canadian patients followed for 5 years, comparing folic acid and B12 versus placebo. Once again, the homocysteine level dropped by 18 to 20%, but actually more patients in the supplement group were hospitalized for unstable angina, and there was no difference compared to placebo in the rate of heart attacks, strokes, or cardiovascular deaths. And once again, the baseline homocysteine level was a statistically significant predictor of cardiovascular events. In each case, the homocysteine levels at the beginning of the study helped to predict the patient's risk, but adjusting the levels with B vitamins did not adjust the risk at the end. Wait, but what does this mean? How can this make sense? So, after I built up such a good story, you might be feeling a little confused. Why didn't the study show a benefit? If high homocysteine was still associated with cardiovascular risk, and the vitamins lowered homocysteine, why didn't it help? There are a few possible explanations. It's possible that the homocysteine levels just weren't reduced enough, or the vitamin doses should have been higher. It's also possible that the B vitamins were causing harm in some way, and that directly offset any benefits from lowering homocysteine levels. More likely, however, the explanation is that this is a classic case of confusing correlation with causation, which leads to storytelling instead of science. You'll notice the kinds of studies I mentioned in the earlier portion of this video: case control, observational, epidemiological, cohort, etc. These are storytelling studies. Scientific studies are, by definition, placebo-controlled, double-blind, randomized trials that focus on outcomes like heart attacks, strokes, and death, not markers like lab test reductions, stents, or changes on scans. You'll also notice that I used very careful language throughout the storytelling. I said there was an association or a relationship. I never said cause or leads to. But human minds are storytelling engines. We search for meaning, we search for cause and effect. So your mind, without you realizing it, decides which thing is the cause and which thing is the effect, based on your pre-existing biases. We have a cultural bias that things in our blood cause diseases. That bias comes largely from cholesterol science, and the same people, like Peter Attia, who have done so much to debunk the classical cholesterol story, still fall prey to the bias that underlies that story, that something in our blood is elevated and we can optimize our health by adjusting the level of that thing. They don't go deeper to realize that the entire method is flawed, because without a placebo-controlled trial, even beautiful stories are often wrong, just as I showed for cardiac pain in my video on Orbita, and just as we're seeing here with B vitamins, and just as they themselves help to point out with cholesterol and heart disease. Because of our bias, when we hear X in blood is associated with Y, we subtly assume that X causes Y. We saw that recently, again, with discussions of blood levels of erythritol being associated with stroke. But in fact, Y could cause X. There could be some subtle changes in damaged blood vessels of the heart or brain that cause homocysteine and or erythritol levels to go up. Or even more likely, both X and Y could be caused by Z. Just like ice cream sales are associated with murders and shark attacks because all of those go up with warmer weather. There can always be unconsidered or unknown factors contributing to any association. The beauty of the placebo-controlled trial is that it establishes cause and effect. If you take this medicine, your risk goes down. If you adjust this metric, your risk changes. One of the reasons I push my patients to get their VO2 max checked and to work on improving it is because unlike any blood test yet created, we have decades of experience showing that changes in VO2 max actually correspond to changes in cardiovascular risk. And yet, our cultural bias tells us that the answer must be in the blood. How can I know if a blood test is any good then? Homocysteine is one of the few things where we've actually done a placebo-controlled trial to test if adjusting the marker adjusts the risk. It doesn't, but it's become a classic example of how we can go astray. The preliminary studies I mentioned before showed this association. B vitamin causes decreased homocysteine. Homocysteine is associated with coronary artery disease. Most people looking at that combination inferred this. B vitamins decrease homocysteine, which should lead to decreased coronary artery disease. But the placebo-controlled trials actually showed that B vitamins led to decreased homocysteine levels, but there was no change in coronary artery disease. And a possible explanation of that is something like this. The B vitamins and the coronary artery disease affect homocysteine levels. I'll do a more comprehensive video on this, but in order for a test to be reliable, it must meet the following standard. The test must be analytically valid across time, meaning they must be accurate if measured at different labs or different samples from the same patient. They must have enough accuracy, sensitivity, and specificity to be useful. It must be actually associated with a meaningful disease or outcome. The test must be prospectively validated, that is, it must effectively predict the disease in a never-before-tested population. The test must be intervenable, that is, changing the test result must correlate with changes in the disease risk, no matter how you change the test value, whether you use medication, vitamin, or lifestyle. The ultimate dream is individualizing the context, but most companies skip the previous steps to market individualized medicine. Very few cutting-edge biohacking companies are doing anything like this kind of research to show that their tests are valid markers. The key element here is number 3. That's where the placebo-controlled trial comes in. If you don't see a placebo-controlled trial, then be aware that you're not following science. You're just following a story. And once again, sometimes that's okay. We all follow stories in some way or another because we have to. There is too much that science doesn't know and, frankly, may never know, just because doing the studies would be unethical or impractical, like in nutrition science. My entire practice is based on changing the story around health and wellness, but at least I tell you when I'm telling a story that's based on my feelings or based on intuition, and I don't confuse you by pretending I'm basing my opinion on solid science when in fact it's not. Online marketers and health gurus shouldn't claim the false mantle of scientific authority for their story by throwing around a bunch of bullshit biochemistry to make that story sound more true than it is. Always remember, if A is associated with B, there are 3 possibilities. A causes B, B causes A, or C causes both A and B. If someone tells you there's an association or a relationship, you should ask, where is the evidence to show one of these options is true and the others are false, to show that we really know which direction the causal arrow goes. Thanks for listening. I hope you learned something about homocysteine.